Good evening, everybody, and welcome to I think it's now our 11th or 12th Meet the Consultant. We're in for an absolute treat tonight. We've got Mr. Joel Dunning, obviously from Middlesbrough, if you saw the caption slide at the start, and obviously going to be presenting to us first of all. Usual rules apply, please. Obviously, if you've got any questions, please pop them in the chat room. We've got some questions at the end of Joel's presentation, which we'll be able to ask him. And obviously, if you've got something from what he's been talking about, then please pop it in the chat. And obviously, we'll pick it up as many as we possibly can towards the end. Obviously, we'll aim to finish about 8 o'clock. So, Joel, thank you for giving up your time tonight and presenting for us and speaking to us. We had a quick chat before we just started the webinar just now. He was just telling us about two firsts that he's ever had. So I don't know whether you want to start that and tell everybody about that first, Joel. And then obviously you can then go in with your presentation. But like I said, thank you for giving up your time. It's really appreciated by us. I'll hand over to you.
Great. Well, thank you very much, Duncan, and thanks for the invitation. So my name is Joel Dunning, a consultant thoracic surgeon here up in Middlesbrough, and I have a passion for this thing called pectus, and pectus excavatum is a scooped-in chest. So my chest is nice and flat, and my patient's chests are scooped in. And this happens often in your teenage growth spurt because your costal cartilages grow too quickly. I often tell my patients that they're often surprised that actually all bones don't just grow at equal length. So when my arm grows, my bone stays the same length here, but the cartilage pushes my hand forwards as it grows. And in your chest, the ribs stay the same place, the sternum stays the same place, but the cartilages grow, but they go too fast in pectus. So if you've got a circle and something's growing too fast at the sides of the breastplate, then that can only go one place. Well, it goes in, which is pectus excavatum, or a scooped-in chest, or it goes out, pectus carinatum, or a pigeon chest, and some people call it funnel chest. So I love doing surgery for this. Today, I had a 17-year-old, had very severe pectus excavatum, very scooped in, very short of breath, can only jog 5 minutes, but he has to start to walk, gets very tired, feels dizzy, and he was accepted on the NHS for pectus surgery. And then strangely, so he's my most severe male that I've ever done. He was very severe. And then the other sort of little unique one I had today was my oldest ever patient, a lady that had always had very severe pectus excavatum. She never really knew because she was quite well covered, but she'd always been short of breath. And then as she got into her 40s and 50s, she got more and more short of breath. Then at the age of 70, she was investigated. They were surprised to see this big dip squashing her heart. And so we have actually done an operation for her at 73 years old. But she says her life's just not worth living, how bad her breathing is. So that is the condition, scooped in chest or pushed out chest. The operation we do just brings it forward. There's a couple of ways of doing it. But just in this quick little 20-minute presentation I've got, I was just going to share a few little issues we've had in pectus surgery, because the surgery is quite simple. But getting the surgery has been extremely difficult in the last 4 years, and maybe it'll have some analogies in your own areas, perhaps when we try and get good NHS care for our patients, because we were happily doing these operations until 2019, and then NHS England were looking to get rid of a load of things off the NHS. They looked at 200 things, and they brought out this review that said, "Stop doing pectus surgery," which was a big surprise, a big catastrophe for us. NICE had just done a paper reviewing it. They reviewed 62 papers. This lot reviewed 12 and then only 6 papers because they were told that one wasn't good enough. They only reviewed 6 papers. They forgot to review people with squashed hearts, and they said, "Oh, this is a boob job for boys, get rid of it." Of note, not a single person was an expert on the committee. In fact, I was banned from the committee because they didn't want to have experts on it, because they thought that would bias the outcome. So that was a disaster. This was the NICE guideline that said it was perfectly good to do it. A brilliantly done document, 62 papers reviewed. We put in loads of applications saying, "Wait a sec, this is crazy," and they completely ignored us. This was their literature review that only looked at psychological outcomes, didn't look at squashed hearts. So that was pretty terrible. We fought back, though. We went to the papers. We got our local MP. We had a poor girl called Autumn Bradley, who was only 11, whose heart was really squashed, that couldn't have surgery. He took it to Westminster, had a Westminster Hall debate. This was the picture of Autumn Bradley. I hope you can see on the screen. This is a slice across the middle of somebody. And this is the front where if you can see my arrow, or otherwise at the top of the screen, this is the front of a patient. The bottom of the screen is the back of the patient, and you might be able to see that chest is massively dipped in. Let's see if I can do a laser pointer. Yeah, there we go. Here's a laser pointer. So this bit here is dipping into the chest massively. This bit here should be right at the top of the chest up here. And there's only about a 2 centimeter gap for poor Autumn's heart. And that was why she was so short of breath. So we tried to review all the papers. We got it reopened because of our brilliant MP, but they were really upset with us. So we gave them all these different papers everywhere. We then did a big, huge pectus event with 100 of our patients that came to NHS England, so to Royal College of Surgeons in England. This wonderful lady, Lynn Evans, did a book that you can read for free on the internet called Pectus and Me, of 41 accounts of people short of breath because of pectus, and her kids had pectus as well. And this made a big difference to us. We published the Pectus and Me book. This young girl has got pectus. We notified everybody on our national website to try and fight for our cause. What did they do? Well, this is the lady from NHS England. Well, they very grudgingly said, well, no, but for a very restrictive group of patients, we can do a very small number of operations. Basically, your heart has to be going into an abnormal rhythm. You have to be collapsing. You have to have massive compression like that CT scan, or even have swallowing problems from pectus, which does exist, or need to be having another operation and pectus is getting in the way. Massively restrictive. So we were pretty miffed about that. We argued a little bit more, and then the really good thing is that they then gave us £2 million to do a study in this. So we're just about to do a big, huge study where 200 people will get surgery on the NHS, and we're going to prove that this helps our patients. So there is now a pathway for getting pectus surgery. If any of you have any relatives or know anyone that has pectus and they're short of breath from it, we have a national meeting once a week to talk about your child or your adult. And they can potentially get signed off. We now have this weekly meeting, and we signed off 50 people as being able to have an operation last year, although before the ban we did 300 patients. So just the tip of the iceberg. Here's our national MDT working every week, which is at least a start. We then also wrote a big guideline on what should you do if you have pectus, which I'll go through in a second. But the other big thing is that we got them to give us £2 million to do a study. So we'll do that over the next 5 years, do 200 patients, and prove that we improve people's breathing and swallowing from bringing their chest forwards. We got all these groups together, which was really nice. Loads of different surgical associations to get behind us for this guideline. And the really sad thing is, and I don't know if it's the same in your society, but the NHS were being really ignorant of the psychological impact of pectus. Now, to be honest, the number one problem the patients I have who come with a severely dipped in chest is they hate it. They get teased about it. They hate the look of it. They want it to just be gone. And yet NHS England will not let you have an operation for that. They do not care about the psychological elements of this condition, which I think are psychologically very debilitating. We cannot do an operation if you just hate your chest so much that you're even suicidal. And certainly I've had patients like that. I've had patients that have self-harmed because of it. And yet the NHS do not care about that psychological element, which that really still bugs the hell out of me. Our guideline talks a lot about psychological support. There are lots of conservative things you can do. You can actually put a vacuum bell on your chest and suck your chest out if you're very young, like 10 to 12 years old. Doesn't work if you're an adult. So we talk about that in our guideline. we summarize all the evidence that really to us proves how important pectus is, how it quite obviously squashes your heart. You guys at TOFS know that the esophagus is behind the sternum, and everybody else knows the heart's there as well. So it can squash both. And we summarize a load of evidence about that as a fact. We've got lots of things about our conservative treatment. Vacuum bell is safe. We tell people that everybody that's got pectus with any physical symptoms must be referred to a specialist, which is really important. We talk about this other thing, a chest going out. Now, pectus carinatum still cannot have any operations at all in NHS England. But actually, you can have a brace to push it in if you're young, all the way up to about 16, which is nice. But anybody that misses that boat, unfortunately, still cannot have surgery in England. Now, it's not the same in Scotland, Wales, and Northern Ireland. You can have any surgery you like because they didn't believe this NHS England process. And so it continues. So it's a strange postcode lottery going on in England. And I've even had a couple of young teenage patients go to university in Scotland so that they could get their operation, because the definition of being eligible for Scottish care is having a Scottish GP. And all they do is just register up there and they get the operation. How crazy is that? So with regard to the patient whose chests are poked out, we tell them that it is important, that we should try and brace them, we should see a specialist, and on occasion, we should potentially do an operation. Now, it is really important to note that all operations have risks, and there is not zero risk with the operation. One of the operations is called the Nuss procedure, and although 100,000 have been done in the world, we're aware of 4 cases of people that have passed away. We believe due to poor quality surgery. And the NICE guidelines actually talked about that, said that it should be an experience centre with heart and lung surgeon backup. And I'm a heart and lung surgeon. But on the right, you can see this is a book written by Angela Whitman about her daughter that had incompetent Nuss procedure surgery in the UK. A really, really sad case. I know for a fact it was done by not competent people, but it is one thing we must always remember. If you're going to have surgery of any type, there are risks as well as benefits. So to my knowledge, there are about 4 people that passed away from surgery out of 100,000. That's very low. I've never lost any, but not even got close. But you have to remember the risks whenever you have surgery. So we're very, very cognizant, and I know Angela Whitman, certainly I've talked to her, and it's beholden on us for the memory of her daughter to make sure nobody else has dangerous surgery. Moving on our guideline, we talk lots about best practice for that very reason. The centre must be very expert. It must do lots of cases. It must have everything available. There must be an audit process. We must publish everything about what we do, so you, our patients and members of the public, can have reassurance that we're doing things well. We take photography, we have psychological services, we should have genetic services, because anybody with pectus excavatum, occasionally it's an inherited disorder. There was a question on the chat about that. Yes, we do have families that do all have pectus, and about 1% of pectus patients also have a connective tissue disorder like Marfan's. In fact, I had a patient a few years ago that came who was 17. He had successful surgery, and then 3 months later in my clinic, his dad rocked up, and I said, "Oh, what's the problem? What's wrong with your son?" And he said, "Oh, nothing's wrong with my son." And he whipped his top off and said, "Well, I've got pectus. I'd like you to fix mine." And I said, "Well, so did you use your son as a guinea pig?" And he didn't really answer that, but I think he did. So we mandate that centres should have a minimum number of operations done a year. They should have the ability to deal with all complications quickly and efficiently, even though rare. And that pediatric patients should be seen in pediatric centres. An adult cannot just sort of have a little go at pediatrics. It's a specialist area that specialists should look after. I won't go too much about our protocol, but actually we have this new trial called Restore. Anybody with severe pectus who has any physical symptoms can come into it. We're actually going to measure how exercise inhibited they are before operation, then at 1 year and 3 years. And we will definitely, we know for a fact we're going to prove it's the right thing to do. The thing you might be interested in is now the NHS, when they sponsor a very big study, they want the outcome measure to be a patient-reported outcome measure. They want us to prove that patients get better directly. So the number 1 outcome measure is going to be the patients saying they feel physically better. That's a big step forward from the past, because in the past we used to just have as outcome measures numbers on screens or gradings. But actually now one good thing is the NHS wants to make sure you as a patient gets better, not just quacks like me look on a screen saying, well, I can't understand it, you should be better, but you're not. So that is a little good thing about our study, which I like. And this will conclude. It'll take 4 years to do, which is a shame. But actually, we should get a huge number of patients through this to get surgery that they very much deserve. What have we done? Just what is the future? Well, we've got a charity as well. I was really pleased to hear about your amazing charity. As professional people working for it, it's really good fundraising, so you can do the things you really want to for your patients. And again, for us, we've just set up a Pectus charity, and the thing we most want to do with the charity is awareness. We want to tell people this is important. Unfortunately, the worst thing about NHS England banning Pectus surgery for 4 years is that it sent out the message that it was trivial, it was unimportant, and it didn't matter, and GPs should tell you to go away. So this is now not the case. It is not trivial. It's not unimportant. You must see a specialist, and you must have the key tests if you've got any physical symptoms. But the damage has been done, and most GPs aren't aware of that. So our charity wants to go out there and tell people, tell the media, tell MPs, tell everybody that basically, these people are important patients. We've got our international guideline now. We're doing our study. We are making the alternative treatments available, and that's making a difference. And of course, with our new national MDT, we are actually talking about Pectus every single week. And myself in Middlesbrough, we're now an allocated, assigned national NHS Pectus centre. There's only one other adult Pectus centre, which is in Barts, and there's only one paediatric Pectus centre in the whole country, and that's in Alderhay in Liverpool. There were 28 centres doing it before the ban, so we're now down to only 3, but they are 3 very expert centres, so at least the patients that come to me are going to get what I hope is the best care possible. We are going to open more centres for the study, because I think that's not enough. I think we are harming patients who are not engaging with us just for a chat. Because probably, as you might know, the reason you've gone to TOFS is because you probably didn't know enough about the condition and wanted to engage and hear more about it. And that's just the same with our patients. They need to talk to experts, even if they don't want an operation. I see 200 patients a year, and I probably operate on only 20% of that number, because most people just want information. The next most common thing is conservative treatment, and only the severest need surgery. And that's probably the same for all conditions. You must get access to experts so that you're better informed. And that's what these charities like TOFS and our Pectus charity hopefully are going to be like. They're going to be brilliant for giving you the information you need. So I'm still quite sad and frustrated about lots of things. Number one is we don't talk about psychological distress. I'm sure it's the same in TOFS, that people might talk more about the swallowing than the effect on the person that this has. We cannot talk about the psychological distress of severe pectus excavatum. Our study, we hope, will prove that it's important. We've embedded it, even though we're not meant to. We're going to sneak it in. Nobody with very severe pectus carinatum, a poked out chest, can have surgery, even if it's severely psychologically distressing. And at the moment, the conservative treatments are just a little bit strange. We need more people to make this available. But that's our little frustration. But this is us and our little team. My most common operation is called the Nussbaum procedure. It's so common. My number plate says Nussbaum now. My team bought that for my 50th. Which I'm very grateful to them for, and that's Pectus in a nutshell, really. So I talked for about 20 minutes. I've actually got a few questions that you guys have submitted, but maybe I'll just ask Duncan if he wants to open it to the floor or he's got any questions, and we'll take it from there.
Well, if we start with the questions, first of all, thank you for that, Joel. Really informative. I've certainly learned a lot from it. So, and it's making me go back and ask a member of staff at work who is actually really short of breath and has been for the last couple of years and really struggling to actually even just walk down the corridor. So it's one of the things I'm going to go back and ask her first thing tomorrow morning at school. So yeah, that was brilliant. Right, so if we start with the questions, I can see there's a couple of questions dropped in the chat box as well. So we'll come back to those in a minute. But the questions that we've had submitted was, I found out that I have an aneurysm in my aortic root. They said it's probably congenital. should I be seeing a cardiothoracic consultant?
Yeah, thank you very much. I'll answer that in just a second. Just winding back to your colleague who's short of breath. The NHS is a very quirky thing at the moment. So this is a meet the consultants, and I have lots of friends and colleagues that have symptoms they're getting very frustrated that they can't see doctors about. So, and I get very frustrated that people aren't getting the care they deserve. I think our complete GP system's broken, but you can find really good clinicians if you try hard enough. So I massively strongly encourage everybody on this call, if you're frustrated, if you want to see somebody, you absolutely can see somebody. It's your right on the NHS to be referred to anybody in England, not just somebody local. You're allowed to be referred to anybody you like. I'm allowed to go to my GP with a gallbladder problem, say, refer me to Lord Aradazi at Imperial. I'm allowed to do that. He doesn't necessarily have to say yes to the referral, but actually, because he doesn't get many like this, he probably would say yes. I get referrals from all over the country for lots of thoracic things, not just pectus. And there's some pain syndromes, there's some shortness breath syndromes because of Facebook and things like that. And I just think it's very sad that people don't use this more often. So my message to anybody is make sure you get seen and fully investigated. If your GP is being a barrier, go to some of the online GP health services now. There's one called Babylon Health. You can get for 15 quid, you can get a GP on FaceTime, and you can say, all I want from you is an NHS referral to X, Y, or Z. I've researched them. I think they'll be great. I think they can help me. So, and if that doesn't work, go to your GP practice. Say, I just want to be referred to person X, Y, or Z. And so shortness of breath, I mean, literally, your GP should do some very basic tests, lung spirometry, take a good history, listen to your heart, listen to your lungs, and then take it from there. If they're not sure, they need to see a respiratory physician. If they don't have any abnormalities, they should see a cardiologist. And interestingly, a friend of mine who was 50 was short of breath, didn't know why after a viral illness, couldn't do anything with his GP. So I sent him to a respiratory physician who did some tests, who went, actually, it's your heart. It's just seen a heart doctor and his heart's wrong. There's a problem, a really important problem. And he's benefiting now from having not accepted the answer no when he was told to go away. So that was just a little thing with your friend. Obviously, got pectus, come to me. If they haven't got pectus, go to a GP, respiratory physician, cardiologist, get all the tests. Don't accept being told to go away and come back in 3 weeks' time, or 3 months, or 3 years. Just about an aneurysm in the aorta. So the aorta has got lots of bits to it. The aortic root is the very beginning of your aorta. Then it goes ascending, arch, descending in the thoracic aorta, and then there's an abdominal aorta. Different bits of them can dilate. Now, they can dilate to very different sizes. If you know what your size is, this question person, you can go to the internet and you can see, how big does an aorta have to be before you need an operation? Because I would very much hope that if you can get a copy of your echo report, which would have had this on, hopefully it'll say something like 2.5 centimeters, 2.6, and you'll look at the internet and you'll go, oh, phew, I don't need emergency surgery. I just need to know the answer. I need to know an expert who says, okay, we follow these up. This is what we routinely do, and I'll put you in a follow-up program. That's probably the most important thing about the aortic root. But the other thing is, an aortic root being dilated can mean you've got a congenital problem. So most people with a dilated aortic root will be checked out for Marfan's and a few other connective tissue disorders like Ehlers-Danlos and a few other things. So if you've got a dilated aortic root, the answer is you shouldn't see a cardiothoracic surgery consultant, because all we are plumbers. You should actually see a cardiologist if you're an adult, and if you're under 18, you should see a pediatric cardiologist. And as well as being put in a follow-up program, you should say to them, could this mean I've got Marfan's? Could this mean I've got some other connective tissue disorder? That is my long answer to that quick question.
Okay, thanks for that. That's great. Another question. Are these abnormalities evolving, and do they need them to be some sort of intervention? I think it's a follow-on from the previous question.
So if it means, can an aortic root get bigger? It can, but it doesn't have to. There's been a really great development in Marfan's with dilated aortas, where people get on a really good tablet that lowers their blood pressure and for some other reason slows the enlargement of the aorta. So actually, if you're diagnosed as having Marfan's, you will find all about that on marfans.org, the Marfan's organization, and they will tell you about all these great tablets to stop it getting bigger. But then also you'll be kept safe by having regular scans. And of course, if it is very big, then the surgery is very safe for it. The mortality is less than 1% to have your aorta sorted. And so, we can fix you as long as it's monitored is the answer. That's probably the answer to that.
All right, that's great, thank you. And then, can chest deformities such as pectus excavatum be genetic? My husband has this, and our little one who's a TOF. Are they connected? Could they be connected?
Yeah, so there are people whose parents have it, and it runs a little bit in families, but we don't know the genetic reason. There isn't a test for it. And then there's some people that have Marfan's, and that is a genetic. It's one of the criteria for Marfan's. It is getting pectus, so it does go with a few conditions. But let's say, some members of your family have it. I guess it can predispose your kid to it. Now, that bit's not important. The important bit is if your kid has pectus, then what we do in very young kids is we wait until they're old enough to comply with this thing, which is called a vacuum bell. I hope you can see it on the screen for those of you watching. But basically, this goes on your chest, and the child inflates it every night. It pulls your chest out brilliantly. And the way it works is you just keep it on for about 4 to 6 hours a day in the evenings when you're coming in to do your homework. And because your body's remodeling all the time, within about 18 months or 2 years, it should have a really good effect on getting rid of the pectus. The reason I say 8 years old, not 3 or 2 or 1, is because 3 or 2 or 1 year olds will not comply with that. They'll just shake it off and cry and moan and whinge and yell and scream. So you just can't treat a 3-year-old, but you don't need to, because it's absolutely fine to wait until they're old enough to say to your child, just, oh, right, you have a dipped chest, it can make you not feel happy about your chest. And also sometimes it can make you feel short of breath. Would you like to fix it? Because if you'd like to fix it, there's this vacuum bell. And I often have kids going 6 and 7, no, no, no. And then you see them at 10, they're like, yes. So you have to wait until they're ready. And then when they're ready, they'll comply. Now, you have to do this treatment before about the age of 12 to 14, but before that's absolutely safe and fine. And get on Pectus Support UK to listen to the accounts of lots of other parents about their vacuum bell treatment. That's where all our patients are. So, because Facebook's a great thing, isn't it?
Okay, that's great. Thank you. Next question. My son had pneumonia last month, and a chest X-ray was recommended. The results show a partially fused ribs. Is that a matter of concern?
Fusion in themselves isn't a concern as long as the shape of the chest is okay. Some people have fused ribs. So you may have had trauma in the past, or it may just be part of who you are. So I wouldn't worry at all as long as the shape of the chest is absolutely fine. Even if the shape of the chest wasn't that great, as long as your kid's very happy with it, has no symptoms, no physical or mental symptoms, I wouldn't worry about it. If they had physical or mental symptoms and it looked very abnormal, then if they're very young, again, we can brace it and push things in or suck things out if they don't like the look of it.
Okay, that's great. Is chest wall deformity relevant to postural care?
So I'd say that a lot of people with pectus excavate and then stoop forwards and get a bit of a kyphosis, a little bit because they're a bit embarrassed about it. There's an association with scoliosis, a sideways wiggling spine. So scoliosis is when your spine wiggles sideways. Kyphosis is when you bend forwards. So they're two very different abnormalities of the spine, and they can go together. So there is some physical exercises for people with pectus. They are sort of, you can look them up very easily on the internet. They're sort of just keeping posture, keeping your chest back. There are also posture braces that you can buy that actually are quite reasonable on Amazon, and they just have 2 straps on your back and then go to a back plate, and they sort of pull your shoulders back a bit to give you better posture. And actually, they're not too bad, but again, you have to engage usually with a child to say, would you like to wear this? Because if you try and enforce it on them, then they won't comply. But if you go, oh, you get a bit of neck pain, bit of back pain, would you not rather have a straight back? Would you like me to buy you one of these? then maybe they'd say yes. So I think it's only a concern if the kid doesn't like being stooped forwards.
Okay, thanks for that. Next one is a bit more of a tough, perhaps a specific one. I have OA long gap and tough, and but part of my bottom rib on the right-hand side of the rib cage is missing. And they're going to say it's basically an upside down shape, not curved. What's the cause of that?
Yeah, so it's quite a rare condition called a partially fused sternum. So your sternum should come all the way down to the bottom of your chest, but there is a condition where you can not be fused, and it can really come quite high up. So that sounds a bit like what they are describing, a bit of rib cage being missing, i.e., this hasn't fully fused. Now, again, it doesn't matter as long as it's not dug in or not abnormal in shape. It doesn't. It's not that important for protection of your chest. We don't tend to fix them, particularly just because they're not fused. Occasionally, some people get pain, and then we can address that. But actually, it's not something that I would operate on if there was no particular problem. And it is a condition that is known, but it is quite rare, really.
Okay, thanks for that. Right. Just something slightly different now. One of our other trustees has just messaged to say she has a question, but she wants to ask it verbally. So hopefully the office have now put Claire on, who's one of our other trustees, and she's got a question for you. So Claire, over to you.
Yeah, I am a troublemaker sometimes because I thought I wouldn't get it all into the questions and answers. But I just wanted to say first that I found your talk really, really engaging, and I've just been engrossed in your enthusiasm as well. And it's just really, really nice to hear. Thank you. But with my questions, I'm going to do it more of a general question more than going into my son's issues. But one of them is chest wall deformities. Can they be mild and slightly visible and still cause issues,
Well, it's a very good.
such as breathing issues?
Yeah.
Yeah.
Yeah. So yeah, that's a very good question. Thank you for your compliments. I can honk on about this for hours and hours, and I've put videos online of me honking on for hours. So I tried my very hardest not to rant, but yeah, but we've been advocating for our patients for quite a while now, and we love our dented friends, so we try and look after each other, and we try and look after them because they are genuinely my most grateful patients when you do come to help them, which is really nice. And so us as clinicians love to help grateful patients, and we love to see people's lives changed. So that's why we're passionate about fixing these patients who we think have been harmed by the NHS process. So the grading of mildness I don't like in chest wall abnormalities. A gazillion GPs send me letters saying this patient has mild this and mild that, and you see them and they're not mild at all. The second thing is if a pectus excavating, you can't tell by the outside, so you've got to have a CT scan to tell if something's mild, moderate, there. My 73-year-old lady, you can hardly see anything on the outside, but on the inside, she's very severely squashed with her heart. So I really hate and actually often berate GPs that send a email saying, "Hello, can you see my patient with mild chest wall abnormality?" And then I send them a CT scan with it very blatantly severe, saying, "I didn't know you could grade it from the outside because I see 200 people a year and I can't grade it from the outside. So you'll have to teach me your trick. But you've got it wrong in this case." So if you're short of breath and you've got a chest wall abnormality, get it checked out. So a CT scan will tell you if it's mild, moderate, severe, not just someone staring at you. So I think it's a big mistake to try and allow GPs to try and guess with chest wall abnormalities. They just don't see enough. The incidence is 1 in 500 to 1 in 1,000 of all pectus abnormalities. So if a GP has 2,000 patients on their list, then they have 3 pectus patients on their list. So how are they experts? The answer is they're not, but they're not meant to be experts. They're meant to be, they treat the common conditions and they refer the rare conditions or anything they don't know about. That's what they're meant to do. So yeah, the answer is get checked out officially.
Yeah. Thank you. And then my other question was, can a lung function test come back really, really good, but there's still something going on because the patient is experiencing breathlessness still?
Yeah, that's a great question because a lot of pectus patients get this as well. So you're very short of breath. Someone does some lung function, says normal. Then they get a heart echo test. It says normal. Now, all these tests are done static when you're still, when you're not short of breath. And then you get up and jog out of the room where you've just had it and you're short of breath. So they've done the test when you're static. And so the heart looks normal, the lungs look normal, and everybody tells them they're normal. But actually, you haven't tested them when they're exercising. So most pectus patients will have a normal lung function and a normal echo, and then we'll do something called a cardiopulmonary exercise test, which is mandated for every single pectus patient for the investigation of their problems. And that is the most sensitive test. We exercise them to exhaustion for 10 minutes on a bike with a mouthpiece and ECG dots, so we can look and see, is this person behind what they should be for somebody their age and gender. And all the time we see people with normal lung functions, normal echo, having 70% of what they should have at their age and gender. So we always use this quite expensive test that's quite difficult to get, and no GP has access to it.
That's very useful, and that's really answered one of my questions and queries I've actually got at the moment for my son. So thank you very much.
No problems. You can actually get a private cardiopulmonary exercise test if you find complete and utter barriers everywhere. They're about 600 to 800 quid. But really, if you've got a good pediatric or adult service with you, just say, look, they're short of breath. They're telling me they're short of breath. Can I have a cardiopulmonary exercise test to show me or whether they are like a normal kid, their age and gender or not? So
exactly, and you've answered my arguments there, where they've said his lung test is 110%, and I've said no, and I've actually showed a video to them of him just getting excited and talking to me, not holding a sentence together. So they've gone, okay, let's look at it more. So I think it is to everyone out there, take some recordings if you can as well, to show what's going on, and to encourage that test as well if we can. Thank you very much.
All right. Thanks, Claire. Thanks for that, Joe. Right, we've got some other questions in the chat room. So, first one is my 3-year-old was born with pectus excavatum, but no specific review has been undertaken on this aspect of his condition. Is this something we should follow up on now? And is there anything we can do to help reduce future potential impacts, i.e., exercise, things like that?
Yeah, so the answer is, if I actually have calls with 3-year-olds and 1-year-olds and 2-year-olds, and every time I show them the vacuum bell and I say, wait till they're about 8 or 10, there's no real answer. But when you show them that on the internet and they go, yeah, I'd really like to wear that for 4 to 6 hours a day to make my pectus go away, that's when you should come and seek advice. If you want to come and chat earlier, that's fine. That's what I would tell you. And that is generally what we do. It really, I haven't yet met a 3-year-old that has needed an operation at the age of 3. In the very early days, they used to operate on people that early, and it was not good at all, because you actually cause a big problem with the growing chest. And they got some really, really bad problems from trying to do an operation on ribs before they were old enough. So we need to mature them. We need to put the vacuum bell on them. And then if that doesn't work, we operate in the teenage years. So that's the answer to that.
Okay, thank you. Another question. This is summarized from a few things that a member has sent through. And she said, I currently live in Scotland and receive art psychotherapy sessions, apparently, which is really rare and obviously to be referred to. Would you be able to link your services with the mental health services through a pathway or through a website, or would you be willing?
So, well, I'd love to get as much access to psychological care for my patients as possible. So the best way is probably for your great submitter to pop on Pectus Support UK Facebook group and say, hey guys, anybody suffering, here's some great psychological support. That'd be amazing. We'd love to link up with your organization just for psychological support. That's so important. That's why patients getting together is so useful. We actually have a psychologist that my patients unfortunately have to pay for. They'd have to pay very much, but that gets them a very good service, £50 an hour. That's quite a lot. But yeah, I think that's great to hear that there's a good service, because it's all too needed in the NHS, and there's far from decent provision for psychological support.
Okay. Right, another question. I have restrictive lung disease. also severe. Also severe kyphosis and gastric pull-up from esophageal atresia. Chest capacity is down to 48%. Can anything be done?
So kyphosis is leant forwards and scoliosis is the spine's probably wiggling. So that can cause a reduced volume of your lung. So if you imagine your lung as a big, huge cage, then squishing it forwards and twisting it sideways is going to reduce the amount of space for a lung. So the answer is your expert respiratory physicians should have a CT scan of your thorax. You should have lung function tests, cardiopulmonary exercise tests. And what can be done? Well, obviously, restoring the volume of a chest is something possible to do. But obviously, you would have to discuss that with the people looking at your scans because obviously you've got very severe scoliosis. We do operations to straighten that. That helps. If you have a little bit of pectus, we straighten that as well. But sometimes the look of it, it can be difficult to fix it because we have to only do the very severest because obviously having an operation is a big deal. So I'm afraid the answer is a bit go see a specialist, but I would get an exercise test and a CT scan and say how much restriction you've said, and can I make bigger volumes in my chest or not is the question really, which your physicians should try to answer for you.
Okay. Next one. So my daughter's chest pokes out on the right. She's 14 and has fused ribs, and I was told that that's what's causing the deformity. But we never seen a cardio specialist. She has low lung capacity. Is it worth seeing a specialist?
Yeah. So if something pokes outwards, then the treatment for outwards is a brace. So this is a special 3D reconstructed brace for anybody with something that pokes outwards. You come to my department, they take a special scan. This is made specially for you. So this is made for somebody with quite a central protuberance. It's very nice. You just wear it around your chest like this. You actually wear it 24 hours a day. And because you wear it 24 hours a day, it takes half as long to work as the vacuum bell because you can wear it under your clothes. So if she's got a bit of rib poking out on the right-hand side, if it looks very obvious and horrible, and also if you can press it flat with two hands, which is what the brace will do forever, and if she would like it to be in that position, then it's certainly worth undergoing bracing treatment. Of course, if she has symptoms of shortness of breath, I would want them investigated fully as well to see whether she has a pectus abnormality, etc., etc. That should be investigated, not ignored. The NHS pathway for all pectus abnormalities says if you have physical symptoms, you must be fully investigated on the NHS with echo lung function, CT thorax, and a cardiopulmonary exercise test. And the reference to that is on our society website. So fight for your rights.
Definitely. Right, next question. To what extent do previous surgery previous surgery complicate pectus surgery? Specifically, a gastric pull-up with lung function now at 70%, normally attribute to pectus in somebody who's aged 8.
So I'd say that on January the 4th, one of our early patients was a peg-fed lady who had a very severe swallowing problem, not due to pectus. So not too dissimilar to your people, and it made no difference whatsoever to us fixing her chest. You can fix it from the outside without going inside the chest at all. You can pull it out. So that's not a problem. Having previous surgery, the most important thing is having all the tests to check the reasons for your shortness of breath and getting the age right to fix it, because probably I like to fix chests in teenage years usually, but that depends a lot on how bad the restriction is. But no, you should not be thrown out or ignored because of previous surgery.
Yeah, that's great. Thank you. And our member who was from Scotland has also sent us another message which says apparently the Anchor Glasgow Psychological Trauma Service have been brilliant. So it might be something for, because it's not, obviously Scotland's not too far away from Middlesbrough. It's a lot closer than we are in the Midlands anyway. It might be something you could perhaps use in the future as well. And other members can use that as well if they can get referred to it. Another question. Can pectus excavatum exacerbate chest infections, especially with a gastric pull-up?
Exacerbate a chest infection? Yeah, so quite a lot of people come to me saying they get a lot of chest infections. So it's not something I've ever done an operation just for, but I would then also do lung functions if they get a bit short of breath, if they've got a collapsed little lobe from being compressed. And actually, if you investigate people fully who've got pectus excavatum, they have lots of other symptoms. This person may be noticing infections worse, but might be short of breath all the time. So the answer would be absolutely, let's do all the tests for you.
Right. I think we've got to the end of all the questions. Lots of people have said thank you for answering their questions as we've been going through them. So obviously, we'll hang on for one more minute because I need to talk for a few more minutes anyway. So if anybody's got anything else, please do pop it in the question in the function. I just want to reiterate what Claire said. You know, it really has been great listening to you talk and obviously your enthusiasm for everything you do. Part of what you're doing, you're partly ahead of us at the moment at TOFS, because obviously we've done a position paper about we want centres of excellence and things like that, and it should only be done in certain areas. And having, you know, only 1 in 3,500 babies born with TOF-OA, it really does, you know, we do need those centres. So, you know, it's great to see what you're doing and where you're up to so far with that, and obviously how things are linked through. So thank you for giving up your time tonight. It's been, like I said, it's been completely fascinating. So I've thoroughly enjoyed it. And obviously coming straight from surgery as well, you know, we know your time is precious. So, and you know, we do appreciate you giving up your time. So thank you very much. For our members, please, obviously you will be getting a questionnaire for, oh, hang on, there's some stuff come through. Let me just check. It's just all lots of thank you saying that you're amazing, and thank you for the amazing information. So it's, you know, really good for that, and obviously, so thanks for that. Please, obviously, do answer the questionnaires that you get sent from the office, and obviously, we will be having more meet the consultants in the future. So please keep an eye on our website, and obviously, Joel will put some links through to Pectus, certainly on our website. And obviously, likewise, if we can try and get the Pectus Society to do the same for us, that would be great. And then obviously we can then do a lot more work perhaps together. So thank you very much. And I will bid you all good night.